Today we are going to talk about complication of suppurative otitis media. Complications of suppurative otitis media can be divided into extracranial complications, cranial complications, and intracranial complications. Extracranial complications like external otitis and lymphadenitis will be discussed elsewhere. So we are going to talk about cranial and intracranial complications. Cranial complications are complications occurring to structures within the temporal bone, while the intracranial complications are complications occurring to structures in the intracranial cavity like the brain, cerebellum, meninges, and large venous sinuses. We are going to start with the cranial complications. These are labyrinthitis, petrositis, facial nerve paralysis, and mastoid abscess. Labyrinthitis, which is inflammation of the inner ear. So how can bacteria pass from the middle ear to the perilymph in the labyrinth, in the inner ear? It passes through the oval or round windows, a fistula due to cholesteatoma, where cholesteatoma erodes the lateral canal, so there is a communication between the middle ear and the inner ear, or through the internal auditory canal or cochlear aqueduct. In these cases, there is meningitis due to as an intracranial complication of otitis media, which passes through either the internal auditory canal or the cochlear aqueduct, which communicates the subarachnoid space with the cochlea, and labyrinthitis occurs. Labyrinthitis can be divided into a serous stage where there is outpouring of serous fluid in the perilymph, but still there is no bacteria. This stage is a reversible stage where if the patient is treated with antibiotics in this stage can be reversible. Second stage, which is the purulent stage. Here there is actual infection in the inner ear and there is pus, and it is an irreversible stage. Once it happens, it has to go to the third stage, which is the fiber stage, which is the healing stage, where the pus inside the inner ear start to be replaced by fibrous tissue. Then we pass from fibrous stage to the osseous stage, where there is ossification of the labyrinth. So the fibrous tissue is replaced by osseous tissue, what we call labyrinthitis ossificans. And as you see on the CT on the right side of the slide, on the right side of the picture, you have a cochlea, normal cochlea, while on the left side of the picture, you see a completely obliterated cochlea, completely ossified, so we cannot see it compared to the other side. What are the signs and symptoms of labyrinthitis? Actually, the labyrinth is responsible for hearing and balance. So both functions will be disturbed. So the vestibular function will be disturbed by having vertigo, nausea, vomiting, and nystagmus. And the hearing function will be also affected by having sensory neural hearing loss, which starts in the high frequencies during the serous stage. When the condition gets worse, when we reach the purulent stage, we have the same clinical picture, but which is more prominent. The vertigo is more prominent, the nausea and vomiting and nystagmus are more prominent also. And for the hearing, we have a total hearing loss. In the fibrous stage, which is the healing stage, the early stormy period is bypassed, and we don't have the severe vertigo, but we have some imbalance, and of course there is complete hearing loss. Further, following after several months, there is full compensation of balance, but we are left with a dead ear. The treatment, in cases of acute suppurative otitis media, We have to do a laryngotomy, which is an opening in the drum to drain the pus in the middle ear and give antibiotics. In cases of in chronic cases, which means the presence of cholesteatoma and erosion by the cholesteatoma, here we have to do the appropriate type of mastoidectomy to remove the cholesteatoma. In these cases, most probably we'll find a lateral canal fistula, which should be dealt with accordingly. Patients with labyrinthitis should be closely followed because infection can spread from the labyrinth to the intracranial cavity, causing intracranial complications. And in these cases, we will find fever, headache, stiff neck, and Koenig sign, which are the signs of neurological affection. So these signs and symptoms you are usually not present in uncomplicated labyrinthitis, but if we start to have them, that means that there was an extension of the infection from the labyrinth to the intracranial cavity, causing intracranial complications. The second complication, which is petrositis, it is the inflammation of air cells in the petrous apex, which is a part of the temporal bone. The petrous air cells are only present in third of temporal bones. That means that only a third of the population who have chronic otitis media are liable to get petrositis. The problem of petrositis that when the air cells in the petrous apex gets inflamed and coalesce together and there is pus inside it, the drainage is very bad because the labyrinth is like a bottleneck hindering the proper drainage of the petrous air cells through the small tracts of cells which connects it to the mastoid air cells, which was the same way from which the infection reached this petrous apex. On the contrary, the mastoiditis is easier to drain either through a perforation in the tympanic membrane or through the Stachyon tube, or even if there is an abscess which is formed, it will be a subperiosteal abscess which is to the outside. While in the petrous apex, the pus is imprisoned and very difficult to drain, and that's the cause of the signs and symptoms of petrositis are pain commonly behind the eye, persistent oral discharge even after complete mastoidectomy, and diplopia due to sixth nerve, the abduced nerve paralysis causing squint and diplopia. The three signs and symptoms constitute what we call Gradinigo syndrome. The treatment, we have to give antibiotics, of course, and do a complete mastoidectomy. Usually cases subside, but in cases where the pus and the complication does not subside, we have to go and drain the petrous air cells surgically. The third complication, facial nerve paralysis. It can happen either in acute otitis media or in chronic otitis media. As we all know that the facial nerve has a course which passes in the middle ear. As you can see on the diagram on the right side, we have we are looking to the right to a right ear with the facial nerve passing horizontally, which is the tympanic portion of the facial nerve. It passes horizontally in the upper part of the medial wall of the middle ear above the stapes, and then it curves at the second genu to form what we call the mastoid portion. So this portion is within the middle ear. Usually it's covered by a very thin layer of bone, but in some cases, like we can see in the pathological picture in the middle, this bony covering can be dehiscent. So when there is otitis media, the pus can be immediately over the facial nerve sheath. So, in some cases, neuritis can happen, causing acute facial paralysis. The treatment of facial paralysis occurring in acute otitis media, we have to do also a myringotomy to drain the pus inside and give antibiotics. Usually the condition side. In some rare cases where the facial nerve paralysis persists, we have to do a complete mastoidectomy with the compression of the facial nerve. Facial paralysis occurring in cases of chronic otitis media, which are cases having cholesteatoma. Here the picture can be a little bit different. We have either a gradual or sudden onset of the condition. Of course, we have a long history of ear discharge and hearing loss due to the pre-existing chronic infection in the ear. It is either due to the pressure by the cholesteatoma or toxic neuritis, and these cases are treated surgically by removing the cholesteatoma and decompressing of the facial nerve. Usually the condition subsides, but the surgery should be done at the proper timing, because if this condition is treated after more than 6 months to 1 year after the occurrence of the paralysis, so usually the recovery is minimal. So these cases of facial paralysis due to cholesteatoma or chronic otitis media should be treated as soon as possible. Now we will talk about the intracranial complications of suppurative otitis media. These are extradural abscess and perisinus abscess, subdural abscess, leptomeningitis, brain abscess, lateral sinus thrombophlebitis, and otitic hydrocephalus. First, before discussing each complication, we have to know how the infection spread from the middle ear to the intracranial compartment. Spread can occur along blood vessels, like retrograde osteothrombophlebotitis occurring in the veins, which can cross from the mastoid to the intracranial cavity. Extension through bone erosion. We all know that cholesteatoma can erode bone, and it can erode the bone, separating the mastoid or middle ear from the intracranial cavity, which is the tegmen, which is the sealing of the mastoid and middle ear. So cholesteatoma can erode it, and we find ourselves immediately on the dura. It can occur also through preformed pathways, either congenital dehiscence in the tegmen or due to fracture due to an accident, or even through surgery, because sometimes while doing mastoid surgery and while cleaning the infected air cells on the tegmen, the bear can open a little window or a little opening in the tegmen, and we can see the dura through it. Usually in such condition there is no problem. We just take care not to enlarge or make this opening and prevent the bear from going inside so as not to tear the dura. But this is a preformed pathway. If the patient has a recurrence of infection, it can be a ready pathway for intracranial infection. And finally, through extension from the labyrinth. We talked about this in the beginning. We have labyrinthitis, and the infection in the labyrinth through the cochlear aqueduct or through the internal auditory canal can pass from the labyrinth to the intracranial compartment. We'll start with the extradural and perisinus abscess. As you can see from the diagram, we have here a mastoid cavity, you have the tegmen, And there is an abscess in black, which is outside the dura. And we have also an abscess just outside the sigmoid sinus. Actually, the perisinus abscess is an extradural abscess because the external covering of the mastoid of the sigmoid sinus is dura. So when an abscess forms on the sigmoid sinus, it is an extradural abscess, but due to its specific location, we call it perisinus abscess. Usually, this condition is symptomless, or even if there is some symptoms, they are very vague. We have some otorrhea, which might be pulsating, low-grade fever, some otalgia and headache, very vague signs and by MRI, as you can see here, we can diagnose the condition. You can see the abscess outside the dura in these MRI cuts. The management, we have also, of course, to do a mastoidectomy, remove the cholecyatoma due to the proper type of mastoidectomy. While the abscess itself, we should not touch it because the dura underlying this abscess might be very friable, and if we try to remove the abscess or open it, it might the dura might open, and we have a CSF leak, and the condition is transformed from an extradural, which is relatively safe or relatively less dangerous, to an intracranial problem because due to CSF leak, which is more dangerous. So we have to do the mastoidectomy and remove bone all around the abscess till we reach healthy dura, and then we leave the abscess to heal by fibrosis. Subdural abscess, here actually the abscess is between the dura and the brain itself. So here we start to have signs and symptoms because, as we know, the cortex of the brain, there is a motor area and sensory area. So we have headache, we have neck rigidity and signs of meningeal irritation, and we have paralysis and loss of sensation on the other side, crossed. We have hemiplegia and hemianesthesia crossed to the other side of. We can have also convulsions and fits due to the cortex, and we will have also can have aphasia because the Broca's area, which is the area responsible for speech, is present in the temporal lobe of the brain, which is sitting just above the middle ear and mastoid. So it can get. Also, this temporal bone, the posterior part of it contains part of the visual area, so we can get what we call homonymous hemianopia, where the patient sees half of the field. The following complication, which is leptomeningitis, which is inflammation of the meninges with the presence of viable organism in the CSF. Here we have a serous stage where there is outpouring of serous fluid due to the infection, but still no bacteria present in the fluid in the CSF. This causes the rise of intracranial pressure. Then there is a cellular stage where there is lymphocytes increase in CSF. And finally, the bacterial stage where there is actual viable bacteria present in the the clinical picture, we have, of course, fever, high fever, hectic fever. We have signs and symptoms of increased intracranial pressure, which are severe headache, projectile vomit. We have slowing of the pulse and high blood. And finally, we have papilledema. Thirdly, we have neurological signs and symptoms, irritation of the meninges, the mental states. At the beginning, there is anxiousness and convulsion, and then there is drowsiness, which ends in coma and death if not treated. We have also neurological deficits. Any cranial nerves can be affected, so we can have diplopia and the squint due to affection. and the terminal stage ends by coma and death. The management is, of course, parenteral antibiotics. This condition should be treated, of course, elsewhere. It's not the ENT who treats this condition, like also the subdural abscess. All these conditions are treated by the neurosurgeons or neurologists. And when the patient's out of danger, he comes back to us to treat the source of infection, which is the we come now to the brain abscess. We have two types of brain abscess. We have temporal lobe or brain abscess, or what we call cerebral abscess, and we have a cerebellar abscess in the cerebellum. The clinical picture we have in the initial stage of invasion, which is the encephalitis, we can have a common picture for all abscess, whether cerebral or cerebellar, like chills and moderate fever, loss of appetite, headache, and projectile vomiting. We have also signs of increased intracranial pressure, which we already talked about, like headache, projectile vomiting, papilledema, and slowing of the blood of the pulse, and increased intracranial pressure. And then there is localizing signs and symptoms, because the function present or the function affected by the cerebral abscess are different from those affected in the cerebellar abscess. So in the cerebral abscess, we will have a picture more or less like the subdural abscess, because the subdural abscess affects the cortex from outside, while the cerebral abscess affects the nerve fibers coming from this cortex. So almost the same functions are affected. So we'll have hemianesthesia and hemiparesis crossed to the other side. We have visual field defects like homonymous hemianopia. We have fits and convulsions. So aphasia, because of the affection of the nerve fibers coming out of the Broca's area. While the cerebellar abscess, we have a picture more or less centered on the balance and equilibrium of the body, because the cerebellum is one of the main centers of keeping the body equilibrium. So we will have vertigo, we'll have ataxia with patients walking on white base, we will have intentional tremors, vertigo, and nystagmus. And we have also paralysis, but on the same side of the body, not crossed paralysis like in the cerebral abscess. We have also all kinds of tests for which depends on the equilibrium will be disturbed, like the pass point. And at the end, there is paralysis, incontinence, and death if not treated. Here we have some imagery with MRIs showing the brain abscess. The treatment, of course, as I said, in almost all the intracranial complications are with the neurosurgeon. They treat the abscess, and then when the patient's out of danger, he comes back to us to treat the source of infection in the mastoid. We'll talk now about the lateral sinus thrombophlebitis. Lateral sinus is the sigmoid sinus. Actually, it occurs with the perisinus abscess, which we talked about in the beginning. And in these cases, the infection passes through the wall of the sigmoid sinus and causes inflammation of the sigmoid sinus, which is what we call thrombophlebitis. In this case, we have three scenarios. The first scenario, which is the best one, where there is a mural thrombosis occurs at the site of entry of infection, and this thrombus will grow and obliterate the whole sigmoid sinus. And the conditions is usually silent because it happens quite slowly. That's the best scenario, and maybe later on this thrombus will shrink and get organized, and there is re-establishment of the blood flow in the sigmoid sign. The second scenario, which is like a middle one, where a thrombus is formed, but infection still enters inside the thrombus, and there is an abscess inside the thrombus. And as bacteria gets nourished by proteins, which are, of course, very plentiful in this thrombus, the abscess inside starts to grow by eating the wall of the thrombus. But each time the thrombus grows, the abscess grows and eats up the thrombus will form further away. And this will lead to a spreading thrombosis or spreading thrombophlebitis in the sigmoid sinus. The third scenario is if the bacterial invasions occurs freely. It enters the wall of the sigmoid sinus, and there is septicemia. Of course, there is fever, chills, profuse sweating, headache, and evidence of pyemia, commonly in lungs and joints. And of course, it's a fatal when there is the spreading thrombophlebitis, which we talked about now, the spread can occur through the mastoid emissory vein, which is a vein which comes out of the mastoid and comes immediately and passes through the bone and comes immediately under the skin behind the auricle. And we have like swelling, puffy, tender swelling behind the ear, with what we call Grisinger's sign. The spread can occur along the internal jugular vein, and we have a tender mass in the neck, and this can spread to the heart and causes thrombosis. And there might be an inward spreading towards the transverse sinus and sagittal sinus, so we become intracranial, and we can get any intracranial complication like meningitis and brain abscess. It can spread also to the cavernous sinus with the many cranial nerve affections. And finally, we can get otitic hydrocephalus. We have here in this angiography, we can see on the picture on the lower row on the right side, we can see the sagittal sinus, transverse sinus, sigmoid sinus, and even the internal jugular vein on the right side of the picture, while on the left side we don't see any of these because due to the thrombosis. And also on the left lower also picture, we can see the sigmoid and transverse sinus on the right side of the picture, while we don't see it on the left side due to the thrombosis. The treatment, we have to give antibiotics. We do mastoidectomy to remove the infection, and of course we will find an extradural abscess which will be treated as we have already discussed before. If there is a complete thrombosis of the sinus, nothing will be further done. But if we find an abscess inside the thrombus, we have to open and drain it to prevent the spreading thrombophlebitis from occurring, because if we leave it, this thrombus will continue to increase in size and causing many complications. The final complication we'll talk about is the otitic hydrocephalus, which is increased intracranial pressure without the presence of any other cranial complication, intracranial complications, which we talked before, like subdural abscess and brain abscess, meningitis, which causes increase in intracranial pressure. It follows several weeks after acute otitis media, not most commonly in children and adults. Of course, the clinical picture This is exactly as we talked before about the increased intracranial pressure. We have severe headache, diplopia due to sixth nerve paralysis. We have vomiting, papilledema, and we have we have also bradycardia, the reduction in the pulse, and hypertension. The CSF is completely normal except that it has a high pressure. The mechanism was at first unknown, but later on they discovered that this condition started by spreading thrombosis, which occurred due to thrombophlebitis, and this thrombosis started in sigmoid, of course, and it passed to the lateral sinus, then to the sagittal sinus. And as you all know, that the CSF is a dynamic fluid. It is secreted by the arachnoid granulations in the arachnoid and absorbed by the arachnoid villi present in the sagittal sinus. So when the thrombosis reaches the sagittal sinus, the arachnoid villi will be clogged and obstructed, and no CSF drainage, which will lead to increased CSF pressure. The management is by eradication of the ear suppuration, by repeated lumbar puncture, diuretics, systemic steroids, and if the condition does not subside, we can resort to a shunt done by the neurosurgeon, which makes a communication between a one-way communication between the subarachnoid space and the peritoneal cavity in order to drain the excess CSF. Thank you.